My name is Johanne Silvain. I'm a professor of medicine at the Sorbonne University. I'm working at the Pitié Salpêtrière Hospital as an interventional cardiologist, and I work as a researcher in the Action group. The ALPHEUS trial is a trial of elective PCI, which is an intervention that is performed very frequently in cardiology. And the actual standard of care for treatment during the intervention is the treatment by aspirin, Clopidogrel, and an anticoagulant. We know that there is stronger P2Y12 inhibitors, which has stronger platelet inhibitors, such as Ticagrelor, that are stronger to Clopidogrel, and that worked well with the improvement of the prognosis in PCI that are performed in the acute settings for patients with myocardial infarction. We hypothesized that in elective PCI, we could reduce the risk of periprocedural MI and myocardial injury by using Ticagrelor as a comparison to Clopidogrel. So the design of the trial, the ALPHEUS trial is the international randomized trial, which is an open label trial. We randomized patients in 50 centers, 49 to be exact, 49 centers in France and in Czech Republic. We selected patients that were undergoing coronary angiogram, and if they had one criteria of high-risk PCI, which could be related to the patient or to the procedure, it was fulfilling the inclusion criteria, and we could randomize it before the PCI to receive either Ticagrelor, Ticagrelor loading dose of 180 milligram, or a Clopidogrel loading dose, which is 600 milligram most of the time. So the endpoint of the ALPHEUS trial was a composite endpoint with myocardial infarctions, periprocedural myocardial infarction, the type A myocardial infarction, type B, which is stem thrombosis, and major myocardial injury, which are the increase of troponin post-PCI. These are defined by the third and the fourth universal definition of myocardial infarction. And we also measure the safety by monitoring bleedings, of course. These endpoints were evaluated at 48 hours, which was the primary endpoint, and also at 30 days. So the key result of the ALPHEUS trial is that there was no superiority of Ticagrelor over Clopidogrel in the protection during the PCI for the reduction of myocardial infarction or injuries. The rate of events was similar in both groups, and there was very few hard events, such as death, stroke, or stent thrombosis, which confirmed that elective PCI is a safe procedure. There was a 8% rate of myocardial infarction that was similar in both groups, and there was a 27% of myocardial injury that was also similar in both groups. When we looked at other endpoints, they were all similar in both groups, so there was no difference in ischemic endpoint at 48 hours or 30 days. In terms of safety, the rate of major bleeding or minor bleeding was the same at 48 hours when patients were discharged after the PCI, so there was a good safety in both groups. But there was an increase of minor bleedings at 30 days, and also an increase of dyspnea in the group of Ticagrelor. So the conclusion that we can make with the ALPHEUS trial is that Ticagrelor is not superior to Clopidogrel in this setting, and that Clopidogrel should remain the standard of care for the treatment during elective PCI in stable coronary patients, and that it's also a safe drug that can be used if the investigator wants to use it for 48 hours. There's no increase of bleeding, but there is no advantages, there's no benefit of over Clopidogrel. The next steps are to look at probably other strategies to reduce periprocedural myocardial injury and infarction. Maybe the physiopathology of these events, this increase of troponin, are more mechanical than thrombotic. And so we have to look for other strategy, techniques, or other drugs to decrease the rates of these rates of events. Take-home messages are that if you use Clopidogrel for elective PCI, it's perfectly fine. For the moment, there's no data supporting the use of a stronger drug such as Ticagrelor or Prasugrel. And that also, if you use Ticagrelor as a loading dose, there's no increase of bleeding for the first 48 hours. However, there's no benefit. So interventional cardiologists should stick to Clopidogrel to perform elective PCI, even with high-risk criteria.